Welcome to the deep dive. Today, we're really jumping into a critical area of med-surg nursing. We're pulling insights straight from Lewis's Medical Surgical Nursing, the 12th edition. Our mission, basically, to make sense of the tricky world of liver, pancreatic, and gallbladder problems. Give you that clarity, that practical knowledge you need. Okay, let's unpack this.
Yeah, absolutely. These three organs, they're distinct, sure, but they work together so closely, like a team. They're all tangled up anatomically and functionally, playing huge roles in, digestion and metabolism. So when one has an issue, it can really set off a chain reaction. You get problems with nutrient absorption, malnutrition, sometimes really significant pain. So today, we'll dig into the pathophysiology, the risk factors, how these conditions actually show up in patients, the diagnostic tests, and crucially, the nursing management, all geared towards helping you connect the dots for, really effective patient care.
Exactly. And we're going to really emphasize that nursing process. So walking through assessment, those priority interventions, patient education, we'll even weave in some brief clinical scenarios just to make it practical for you. So first up, let's tackle the liver. An absolutely incredible organ, does so much, and when it gets inflamed, we call that hepatitis.
Right, hepatitis just means liver inflammation. Most often it's viral, but it can also be caused by substances, like alcohol or certain medications. The Lewis text breaks down the main viral types: hepatitis A, B, C, D, and E. Now, they might look similar at first, maybe some flu-like symptoms, but their transmission routes and how the disease progresses, totally different.
That's such a key point. It's fascinating how these different viruses lead to wildly different outcomes. Sometimes it's a self-limiting thing. Other times it's chronic liver disease like hepatitis A and E, HAV, and HEV. You mainly get those fecal orally, contaminated food or water, and usually the body clears them. Self-limiting infections.
But then you have hepatitis B, C, and DHBV, HCV, HDV. These are typically bloodborne pathogens. HBV, for instance, can spread perinatally from mother to child, or percutaneously, think IV drug use, needle sticks, or sexually. HDV, well, it's kind of unique. It's a defective virus. It actually needs HBV to be present to even cause an infection. And when they occur together, it often means a much faster progression to serious liver disease. And HCV, primarily percutaneous. Sharing contaminated needles is probably the most common route. So what's happening pathophysiologically? In acute viral hepatitis, you get widespread destruction of liver cells, the hepatocytes. And this destruction really messes with vital liver functions, bile production, coagulation, metabolism of glucose and proteins, detoxification, basically everything the liver does. The good news: if complications are avoided, the liver has this amazing ability to regenerate.
But, and this is a big but chronic viral hepatitis can be sneaky, insidious, silent even. It causes this persistent low-level destruction of hepatocytes. Over time, this leads to scar tissue, fibrosis, and ultimately cirrhosis, where liver function is just severely compromised. This can go on for years without the patient knowing. The source also mentions systemic effects early on sometimes, like rashes or joint pain, maybe even kidney issues from these circulating immune complexes. Okay, so what does it look like clinically? Manifestations. Well, with acute hepatitis, a lot of patients actually don't have symptoms. They're asymptomatic. Others might get anorexia, fatigue, nausea, vomiting, maybe some flu-like symptoms, and tenderness in the right upper quadrant. Then there's jaundice. That's the key sign, right? The yellowish discoloration of the skin, eyes. That's from altered bilirubin metabolism. And it leads to that dark tea-colored urine and the pale clay-colored stools. Oh, and pruritus, that intense itching. That's from bile salts building up under the skin.
Right. And with chronic hepatitis, especially B and C, it can be silent for a very long time, years even. But the long-term complications are really serious: cirrhosis, liver failure, liver cancer. In the later stages, you start seeing things like spider angiomas, those little dilated blood vessels on the skin, and palmar erythema, which is red palms, both linked to increased estrogen the failing liver can't clear. And then you get into the really severe stuff like hepatic encephalopathy, confusion, agitation because of toxins building up in ascites, that fluid accumulation in the belly. So how do we tell them apart? Diagnosis relies on specific blood tests, antigens, and antibodies. For example, finding HAV IgM antibodies means an acute hepatitis A infection. Finding anti-HBs antibodies, that means immunity to Hep B, either from getting sick or the vaccine. For hepatitis C, if the antibody test is positive, you then need an HCV RNA test. That confirms if the infection is active and tells you the viral load.
And beyond those specific viral markers, you've got your standard liver function tests, your LFTs. They'll show significant abnormalities: high alkaline phosphatase, AST, ALT, GGT. Also, a prolonged prothrombin time PT, which reflects clotting issues, and increased bilirubin. Now, liver biopsy can be done for a definitive diagnosis, especially in chronic cases, or to see how much inflammation or fibrosis there is. But non-invasive methods like ultrasound elastography, FibroScan is a common one. Are being used more and more to measure liver stiffness, basically the amount of scarring. Okay, so for you, the nursing student listening, what are the absolute priorities? What's your role in managing these patients?
Well, number one is health promotion. Prevention is absolutely paramount. For HAV, that means meticulous hand washing. Simple but effective. For HAV and HBV, vaccination. Kids get it routinely, but also at-risk adults, definitely including healthcare personnel like us. For HBV and HCV, it's all about infection control. Don't share needles, razors, toothbrushes, practice safe sex. And for HCV, while there's no vaccine yet, screening high-risk individuals is critical because we now have these amazing direct-acting antivirals, DAAs, that can actually cure most HCV infections.
Right, and what about acute care? Someone comes in actively sick with hepatitis.
It's mostly supportive care. Focus on adequate nutrition, small, frequent, well-balanced meals. Maybe cut back on fat if it causes nausea. They might need B-complex vitamins, maybe vitamin K if clotting is affected. Rest is huge, both physical and, psychological rest. And absolutely crucial, avoid alcohol and any hepatotoxic drugs, anything that could further damage the liver. If nausea and vomiting are severe, like in one of those check your practice scenarios in Lewis, you'll be giving antiemetics, doing frequent mouth care, maybe even IV fluids with glucose if they can't keep anything down. And for that awful itching, the pruritus. Comfort measures. Antihistamines, maybe cool baths with baking soda, keeping nails short. Now, if hepatitis isn't managed, or from other causes like alcohol, it can progress to cirrhosis. Cirrhosis is basically end-stage liver disease. The liver cells are destroyed on a large scale and replaced by fibrous scar tissue and these little regenerative nodules. It changes the whole liver structure. In the U.S., the big causes are chronic hep C, NASH, that's non-alcoholic steatohepatitis, essentially fatty liver disease gone bad, and alcohol-induced liver disease.
And you mentioned earlier, cirrhosis can be really silent at first. Maybe just some fatigue, or the doctor feels an enlarged liver on exam. But as it progresses, wow, the signs become dramatic. Really noticeable jaundice, peripheral edema, that swelling in the legs and feet and the sides, the fluid in the abdomen. You also mentioned those skin signs, spider angiomas, and palmar erythema, good things to look for. They signal that increased estrogen because the damaged liver can't break it down.
Exactly. And hematologic problems are super common. The liver can't make clotting factors properly, and you often get splenomegaly, an enlarged spleen from blood backing up, which destroys platelets. So patients bruise easily, they're anemic, have low platelet counts, thrombocytopenia, endocrine issues too. Men might develop gynecomastia, breast enlargement. Women can have menstrual problems. And peripheral neuropathy, that tingling or numbness, usually in the feet and legs, often happens due to vitamin deficiencies like thiamine or B12.
Okay, let's really zero in on the major complications. These are life-threatening. What does every nurse absolutely need to anticipate and manage? First, portal hypertension and varices.
Right. The scarring in cirrhosis obstructs blood flow through the liver. This increases pressure in the portal venous system, that's portal hypertension. The body tries to compensate by forming collateral veins, basically bypass routes. But these veins, especially in the lower esophagus and upper stomach, the esophageal and gastric varices, are really fragile. They weren't designed for this high pressure, so they can rupture and cause massive, life-threatening bleeding. Patients might vomit bright red blood, hematemesis, or have black, tarry stools, Melina. It's a true emergency.
And you mentioned a key safety point earlier from the text about balloon tamponade for bleeding varices.
Yes, absolutely critical. If a Sengstaken Blakemore tube or similar device is used, you must keep scissors at the bedside, always. If that esophageal balloon migrates upwards and obstructs the airway, you need to be able to cut the ports and deflate it instantly. It's a potential lifesaver.
Okay, huge safety point. Next major complication, peripheral edema and ascites.
The swelling in the legs and the fluid filling the abdominal cavity. This happens for a few reasons. One, the damaged liver can't make enough albumin. Albumin is a protein that helps keep fluid inside blood vessels. Low albumin means lower oncotic pressure, so fluid leaks out into the tissues. Two, that high portal pressure also forces fluid out. And three, complex hormonal changes like hyperaldosteronism cause the body to retain sodium and water. A big risk with ascites is SBP, spontaneous bacterial peritonitis, an infection of that acidic fluid. Needs prompt diagnosis and treatment.
Got it. And the third big one, hepatic encephalopathy.
Yeah, HE. This is a neuropsychiatric issue. It happens because the failing liver can't detoxify ammonia, which is a byproduct of protein breakdown in the gut. Ammonia is toxic to the brain. It crosses the blood-brain barrier and causes a whole range of symptoms. It can be subtle at first, changes in personality, trouble concentrating, sleep disturbances, but it can progress to confusion, agitation, lethargy, and eventually deep coma. Two classic signs you look for are asterixis, that flapping tremor when the patient holds their hands out, and fetor hepaticus, this characteristic musty, sweet odor on the breath. Lewis has a handy grading scale for HE severity.
Okay, so diagnosing cirrhosis LFTs will be off again, right? Low albumin, prolonged PT, high bilirubin.
Yes, though AST and ILT might actually normalize in very end-stage disease because there just aren't many liver cells left to leak enzymes. Liver biopsy is still technically the gold standard for confirming cirrhosis, but again, that non-invasive FibroScan is really useful for assessing the degree of fibrosis without needing a biopsy.
So how do we manage these complications? Interprofessional care. Let's start with the sites.
Management involves restricting sodium intake, often down to 2 grams per day. Diuretics are key, usually spironolactone, often paired with furosemide. For large volume ascites causing symptoms, a paracentesis can be done to remove fluid. And for really refractory ascites, a TPS procedure, transjugular intrahepatic portosystemic shunt, might be considered to reduce portal pressure, but it can worsen encephalopathy.
Okay, and for varices, preventing that first bleed is crucial.
Absolutely. Patients need to avoid alcohol, aspirin, NSAIDs, anything that can irritate the GI tract or impair clotting. Non-selective beta blockers like propranolol or nadolol are often prescribed to lower portal pressure and reduce the risk of bleeding. If bleeding does occur, it's all hands on deck. Stabilize the patient, IV fluids, blood products, medications like octreotide or vasopressin to reduce blood flow to the portal system, and then urgently endoscopic therapy, either band ligation, where they put little rubber bands around the varices, or sclerotherapy, injecting a solution to scar them down.
And for hepatic encephalopathy, Laxalus is the main drug, right?
Yes, lactulose is a mainstay. It works by trapping ammonia in the gut and promoting its excretion through bowel movements, hence the expected side effect of diarrhea. Antibiotics like rifaximin may also be used to reduce the ammonia-producing bacteria in the gut. The goal is basically to lower the ammonia levels reaching the brain.
So let's translate this into nursing management for cirrhosis. What are your key actions?
Okay, first, health promotion encouraging alcohol abstinence, good nutrition, treating hepatitis early to prevent progression. In acute care, you're focused on conserving the patient's strength, preventing complications of being bedbound, managing that awful pruritus with medications like clostiramine, maybe, and Comfort measures cool baths, soft linens, keeping nails short. For edema and ascites, it's strict I&O daily weights measuring abdominal girth. Lewis mentions marking the abdomen with a pen to ensure consistent measurement points, really practical tip. Positioning is important. Semi-Fowlers or high Fowlers often helps with breathing if ascites is pushing up on the diaphragm. Meticulous skincare is vital because edematous tissue breaks down easily. Watch electrolytes closely, especially potassium levels if they're on diuretics like furosemide. Hypokalemia is a big risk.
And if they have bleeding varices?
You need extreme vigilance. Monitor for any signs of bleeding hematemesis, melena, changes in vital signs, maintain their airway, have suction ready, be prepared for emergency procedures, blood transfusions. It's intense.
And for hepatic encephalopathy?
Frequent neurologic assessments are key. Assess orientation, level of consciousness, look for asterixis. That might be every 2 hours in an acute phase. Safety is paramount. They're confused, maybe agitated, high fall risk. So bed low, maybe side rails up per policy, assist with ambulation, prevent constipation, as that can worsen HE. Administer the lactulose and rifaximin as ordered. Think about that patient scenario, again, Mr. Rodriguez, with ascites and shortness of breath. Your immediate actions: respiratory assessment rate, depth, effort, oxygen saturation, and positioning him upright to ease breathing.
Got it. And long-term ambulatory care?
It's all about follow-up, teaching patients to avoid alcohol and any liver-toxic drugs, including some over-the-counter meds, teaching them to recognize early signs of complications like increased swelling, confusion, bleeding, and when to call the doctor. Lewis has a great table, Table 4826, summarizing this patient teaching, encouraging participation in support groups like AA if alcohol is the issue.
You also touched on liver cancer and transplant briefly.
Right. Liver cancer, mostly hepatocellular carcinoma or HCC, is a major complication of chronic liver disease, especially cirrhosis from hep C or B. Prevention really focuses on treating the underlying viral hepatitis. Treatments for HCC vary: resection, ablation, chemoembolization, but often, because it's found late, the focus shifts to palliative care. Liver transplantation is the definitive treatment for end-stage liver disease and some localized HCCs. It's a complex process, requires extensive evaluation and lifelong immunosuppression afterward to prevent rejection. Post-transplant nursing is highly specialized monitoring for bleeding, infection rejection, managing complex medication regimens.
Okay, great overview of liver issues. Let's pivot now to the pancreas, another really important digestive and endocrine gland. Let's talk acute pancreatitis.
Right. Acute pancreatitis is a serious acute inflammation of the pancreas. What happens is the pancreatic enzymes, which normally help digest food, get activated inside the pancreas itself and start order. Well, autodigesting the pancreatic tissue. It causes intense inflammation and pain. In the U.S., the two most common causes by far are gallbladder disease, specifically gallstones blocking the common bile duct and chronic alcohol use. Hypertriglyceridemia and certain drugs can also trigger it.
And the pain is the big thing here, right? How does it typically present?
Oh, yeah. The hallmark is severe abdominal pain, usually in the left upper quadrant or maybe mid-epigastric. It's often described as deep, piercing, continuous, and it frequently radiates straight through to the back. Characteristically, it's aggravated by eating, and unlike some other GI pain, it's not relieved by vomiting. Patients often also have nausea, vomiting, low-grade fever, a high white blood cell count, leukocytosis, maybe hypertension and tachycardia if it's severe. Jaundice can occur if a gallstone is blocking the bile duct.
You might also see some specific bruising signs in severe cases.
Yes. In severe hemorrhagic pancreatitis, you might see gray Turner spots, that's bluish discoloration on the flanks, or Cullen sign bluish discoloration around the umbilicus. These indicate retroperitoneal bleeding, seepage of bloodstained exudate. They're signs of severe disease. And shock is a major risk from hemorrhage, from fluid shifts into the retroperitoneal space, or from release of inflammatory mediators.
What about complications?
Complications can be local or systemic. Locally, you worry about things like a pancreatic pseudocyst, a collection of fluid, enzymes, and debris walled off near the pancreas, or a pancreatic abscess, which is an infected collection of pus. Both often require drainage. Systemically, the lungs are often affected. Pleural effusions, atelectasis, even ARDS, acute respiratory distress syndrome, can occur. Cardiovascular complications too. And a really key electrolyte imbalance to watch for is hypercalcemia. Calcium levels can drop significantly. You need to monitor for signs of tetany, muscle twitching, jerking, irritability. Tingling around the lips and fingers is an early sign. Look for Chvostek's sign, facial muscle twitching when tapping the facial nerve, or Trousseau's sign, carpal spasm with blood pressure cuff inflation. Abdominal compartment syndrome is another potential serious systemic complication.
Okay, so diagnostics. How do we confirm it's pancreatitis?
The primary lab tests are serum amylase and serum lipase. Both will be elevated, usually significantly. Lipase is generally considered more specific to the pancreas, as amylase can be elevated in other conditions too. You might also see elevated liver enzymes if there's bile duct involvement, high triglycerides, high glucose, because insulin production can be affected, and that low calcium we just talked about.
And imaging.
Imaging is crucial. Abdominal ultrasound might show gallstones, but the gold standard for seeing the pancreas itself, identifying inflammation, necrosis, or complications like pseudocysts, is usually a contrast-enhanced CT scan.
So interprofessional care goals, what are we trying to achieve?
Okay, key goals are relieve pain, prevent or treat shock, reduce pancreatic secretions to let the pancreas rest, correct fluid and electrolyte imbalances, prevent or treat infection, and remove the underlying cause if possible, like gallstones.
And how do we do that? What are the interventions?
Aggressive 4V hydration is critical early on to support blood pressure and organ perfusion. Pain management usually requires IV opioids like morphine or hydromorphone. Positioning for comfort is important too. To rest the pancreas, the patient is kept strictly NPO, nothing by mouth. Often, an NG tube is inserted and set to low suction to reduce gastric contents from entering the duodenum and stimulating the pancreas. We used to use anticholinergics, but they're generally avoided now, especially if there's paralytic ileus, as they can worsen it. Proton pump inhibitors, PPIs, are often given to reduce gastric acid secretion. For severe pancreatitis, nutritional support is important. Early enteral nutrition, feeding into the jejunum past the pancreas, is generally preferred over parenteral nutrition, 5e feeding, because it helps maintain gut integrity and seems to reduce infection risk. Antibiotics might be needed if infection or necrotizing pancreatitis is suspected or confirmed. And if gallstones are the cause, an ERCP with sphincterotomy to remove the stone might be done, or a cholecystectomy, gallbladder removal, once the acute attack settles down.
Okay, and nutrition therapy once they can eat.
When oral intake resumes, it needs to start slowly. Small, frequent meals. The key is high carbohydrate content because carbs are the least stimulating to the pancreas. Fat needs to be restricted initially, and absolutely no alcohol.
All right, nursing management for acute pancreatitis. Top priorities for you.
First, health promotion assessing for risk factors like alcohol use or gallstones and encouraging treatment. In the acute phase, vigilant monitoring of vital signs is crucial. Watch for hypotension, fever, tachypnea signs of shock or complications. Meticulous fluid and electrolyte balance is key. Strict INO, daily weights, monitoring labs, especially for hypocalcemia, and watching for those signs of tetany. Pain management is a huge priority. Assess pain frequently, administer analgesics promptly, and help the patient find a comfortable position, often flexing the trunk, drawing knees to the abdomen, or side lying with the head elevated seems to help. If they're NPO, frequent oral and nasal care is essential for comfort and to prevent peritonitis. Respiratory assessment is critical because of the high risk of pulmonary complications. Listen to lung sounds, monitor oxygen saturation.
And remember that check your practice scenario about the family being upset about the NPO status. You really need to explain the rationale clearly why resting the pancreas is absolutely essential for healing. Okay, let's touch on chronic pancreatitis. How did that differ?
Chronic pancreatitis isn't just one acute attack. It's this continuous, prolonged inflammatory process where the pancreas becomes progressively destroyed and fibrosed. Scar tissue replaces functional tissue. The most common cause, again, especially in Western countries, is chronic alcohol use. But it can also follow recurrent acute pancreatitis or be caused by obstruction from gallstones, tumors, or even autoimmune conditions.
And the clinical picture. Is the pain the same?
The pain can be a major feature, but it might be different. It could be chronic, nagging abdominal pain, or it could be recurrent severe attacks similar to acute pancreatitis. Sometimes, ironically, the pain might decrease as the pancreas burns out, but the big thing you see with chronic pancreatitis are signs of pancreatic insufficiency, because the pancreas isn't making enough digestive enzymes anymore. So patients have malabsorption, leading to weight loss despite eating. They might have constipation, mild jaundice sometimes. And the classic sign is steatorrhea, those bulky, fatty, foul-smelling stools that often float. That's undigested fat. Diabetes mellitus also commonly develops because the insulin-producing islet cells get destroyed too.
So the focus shifts more to managing those long-term consequences.
Exactly. Interprofessional and nursing care focuses on pain relief, preventing further attacks, which means absolute alcohol and smoking cessation, and controlling the pancreatic insufficiency. This involves dietary changes. Small, bland, low-fat meals are usually recommended. And crucial is pancreatic enzyme replacement therapy. Drugs like pancrelipase, Creon, Zenpep, contain amylase, lipase, and protease. They have to be taken with meals and snacks to help digest food. If diabetes develops, they'll need insulin or oral hypoglycemic agents. Sometimes surgical procedures or endoscopic interventions are needed to relieve obstructions or drain cysts.
And pancreatic cancer. Briefly, which we know.
Pancreatic cancer is tough. It's often aggressive, has a poor prognosis, largely because it's usually diagnosed at a late stage when it's already spread. Most are adenocarcinomas, typically arising in the head of the pancreas. The biggest established risk factor, cigarette smoking. Chronic pancreatitis and diabetes are also risk factors, as is a high-fat diet.
And symptoms often mimic chronic pancreatitis, making early diagnosis hard.
Yes, exactly. Symptoms are often vague initially. Dull, aching abdominal pain, maybe radiating to the back, often worse after eating or at night. Anorexia, rapid and progressive weight loss, nausea. Jaundice is a common sign if the tumor is in the head of the pancreas and obstructs the common bile duct.
Treatment options are limited if it's advanced.
Very much so. Surgery, like a pancreatic duodenectomy, the Whipple procedure, offers the best chance for cure, but it's a massive operation. And only about 15–20% of patients are candidates at diagnosis because the cancer has usually spread. Often, treatment becomes palliative, maybe radiation or chemotherapy to try and slow progression, or procedures like biliary stenting to relieve jaundice and itching caused by bile duct obstruction. So nursing care is largely supportive, focusing on adequate pain control, managing nutritional needs, which can be very challenging, ensuring hydration, and providing a lot of psychological and emotional support for both the patient and their family as they cope with a difficult diagnosis and prognosis.
Okay, thank you. Let's round out this deep dive now with our third area, the biliary tract, the gallbladder and its associated conditions.
All right, so we're mainly talking about cholelithiasis, which is gallstones, and cholecystitis, which is inflammation of the gallbladder. These are super common and they often go hand in hand. Lewis points out several risk factors, being female, especially multiparous, having had multiple pregnancies, and over age 40. Estrogen therapy, oral contraceptives also increase risk. Obesity, a sedentary lifestyle, and a family history play roles too. Often remembered by the Fs, female, fertile, 40, fat, though that's a bit simplistic.
So how do these develop? What's the pathophysiology?
Gallstones form when the balance of stuff in bile cholesterol, bile salts, calcium gets out of whack. Cholesterol gallstones are the most common in the US. If there's too much cholesterol or not enough bile salts, the cholesterol can precipitate out and form stones. Bile stasis is another key factor. If bile isn't flowing freely and sits in the gallbladder too long, it gets concentrated and stones are more likely to form. Conditions like immobility, pregnancy, or inflammatory bowel disease can contribute to stasis. Now, cholecystitis, the inflammation, usually happens when a gallstone gets lodged in the cystic duct, the tube leading out of the gallbladder. Bile gets trapped, the gallbladder gets distended and inflamed. This inflammation can lead to infection, tissue ischemia, necrosis, and even perforation if it's not treated. There's also a calculous cholecystitis inflammation without stones. This tends to happen in critically ill patients, often related to prolonged immobility, fasting, or TPN, which leads to bile stasis.
Okay, so what does it feel like? What are the clinical manifestations?
When stones are just sitting in the gallbladder, they might not cause any symptoms. But when a stone moves or obstructs a duct, that's when you get symptoms. The classic symptom is biliary colic. This isn't actually colicky, like coming and going. It's usually a severe, steady pain, typically in the right upper quadrant, though sometimes epigastric. It often radiates to the right shoulder or scapula. This pain typically occurs 3 to 6 hours after eating a high-fat meal, or sometimes just when lying down. It can be accompanied by tachycardia, sweating, diaphoresis, and profound restlessness.
And if the stone completely blocks the common bile duct?
Then you see signs of total obstruction, which are quite dramatic, as laid out in Table 48.22 in Lewis. Jaundice appears because bilirubin can't get into the intestine. Urine becomes dark, amber, or brown because the kidneys excrete bilirubin. Stools become clay-colored because bilirubin doesn't reach the intestine to give stool its normal color. You can get steatorrhea again, fatty stools, because bile salts needed for fat digestion aren't reaching the intestine. Pruritus, that itching, occurs due to bile salt deposition in the skin. And bleeding tendencies can develop because vitamin K, which is fat-soluble and needs bile for absorption, isn't absorbed properly, affecting clotting factor synthesis. Cholecystitis itself presents with indigestion, pain, and tenderness in the right upper quadrant, often elicited by Murphy's sign pain on inspiration when palpating under the right costal margin. Nausea, vomiting, restlessness, fever, and leukocytosis.
Diagnostics. How do we confirm it's gallbladder disease?
Ultrasound is really the workhorse here. It's highly accurate for detecting gallstones. ERCP, that endoscopic retrograde cholangiopancreatography we mentioned with pancreatitis, can also be used. It allows visualization of the gallbladder, cystic duct, common hepatic duct, and common bile duct. Plus, during ERCP, they can actually remove stones lodged in the common bile duct or place stents. Blood tests will typically show an elevated white blood cell count in cholecystitis due to inflammation. Liver enzymes, AST, ALT, ALK Phos, and bilirubin levels might be elevated if there's bile duct obstruction. Amylase might be elevated if there's associated pancreatitis.
Okay, so treatment. If someone has symptomatic gallstones or cholecystitis, what's the plan?
Once gallstones cause symptoms, the definitive treatment is usually surgical removal of the gallbladder, a cholecystectomy. However, during an acute attack of cholecystitis, the initial management might be conservative. This involves pain control, often with opioids. Antibiotics if infection is suspected. Maintaining fluid and electrolyte balance with IV fluids, maybe an NG tube for decompression if nausea and vomiting are severe.
Are there non-surgical options for the stones themselves?
Yes, though they're used less commonly now that laparoscopic surgery is so effective. There's bile acid dissolution therapy drugs like ursodiol or canodiol can dissolve some types of cholesterol stones, but it takes months or years and stones often recur. ERCP with sphincterotomy, as mentioned, can remove common bile duct stones. And ESWL, extracorporeal shockwave lithotripsy, uses high-energy shockwaves to disintegrate gallstones. It's usually used in combination with bile acids.
But surgery is the main approach, laparoscopic usually.
Yes, laparoscopic cholecystectomy is the treatment of choice for symptomatic gallstones. It involves making several small incisions in the abdomen, inserting a laparoscope and instruments. The benefits are huge. Minimal pain, much shorter hospital stay, quicker return to normal activities compared to open surgery. The main potential complication, though rare, is injury to the common bile duct. An open incisional cholecystectomy might still be necessary if there's severe inflammation, perforation, obesity, or previous abdominal surgeries that cause scarring. Sometimes a T-tube is placed into the common bile duct during an open procedure to ensure bile drainage while the duct heals, though this is less common now.
What about nutrition therapy? Low-fat diet always.
After laparoscopic cholecystectomy, patients usually tolerate a regular diet fairly quickly, though they might want to reintroduce fats gradually. For conservative management, or after an open cholecystectomy, a low-fat diet might be recommended initially. Generally, smaller, more frequent meals with some fat might be better tolerated than large meals high in fat. Interestingly, very rapid weight loss can actually promote gallstone formation, so that should be avoided. Gradual weight loss is better if needed.
Okay, let's wrap up with nursing management for gallbladder disease. What are the key takeaways for nurses?
Health promotion first. Teach patients, especially those at risk, about the early signs and symptoms and the importance of seeking medical care if they occur. Don't just dismiss RUQ pain as indigestion.
Good point.
Right.
And in acute care.
Hmm.
During an attack or post-op?
Priority interventions are pain management, assessing pain, and administering analgesics. Relieving nausea and vomiting antiemetics, maybe that NG tube, frequent mouth care is important. Providing comfort measures. You need to closely monitor for signs of obstruction jaundice, changes in stool or urine color, itching. And watch for bleeding tendencies, check PT-INR, look for bruising or petechia. After ERCP specifically, you need to monitor for complications like pancreatitis, increased abdominal pain, nausea, vomiting, perforation, sudden severe pain, fever, or infection.
And that post-laparoscopic cholecystectomy shoulder pain?
Yes, that's common. It's referred pain from the CO2 gas they use to inflate the abdomen during surgery, which irritates the phrenic nerve. The best way to manage it is to position the patient in the Sims position, left side lying with the right knee flexed. This helps move the gas bubble away from the diaphragm. Encouraging deep breathing and early ambulation also helps dissipate the gas. Pain medication helps too, of course. If a patient does have a T-tube after an open cholecystectomy, you need to maintain the drainage system, ensure it's flowing freely, monitor the amount and color of the drainage, protect the skin around the insertion site, and teach the patient how to manage it. Lewis has a great patient teaching guide, table 48.25, for post-cholecystectomy care that's worth reviewing.
Excellent. And ambulatory care, discharge teaching.
Provide dietary teaching, usually low fat initially, then reintroduce fats gradually. Weight reduction if the patient is obese. Explain the symptoms of obstruction or infection that they need to report immediately. And emphasize the importance of follow-up appointments.
Lastly, gallbladder cancer, just briefly.
Right. It's rare, thankfully, but like pancreatic cancer, it's often asymptomatic until it's quite advanced, making early diagnosis difficult and prognosis generally poor. If found very early, sometimes incidentally during cholecystectomy for stones, surgery can be curative. But often, the focus is palliative care, managing pain, nutrition, hydration, and providing support. So reflecting on everything we've covered today, liver, pancreas, gallbladder, we've really journeyed through this complex but absolutely fascinating interconnected system. What stands out is just how vital that interconnectedness is, how a problem in one area can ripple out, and how subtle signs, maybe just fatigue or slight jaundice or changes in stool, can point to really significant underlying pathology. From sorting out the different types of viral hepatitis and their long-term implications, to recognizing those critical life-threatening complications of cirrhosis like varices or HE, and managing the intense pain and systemic effects of pancreatitis. It really underscores how indispensable a nurse's sharp assessment skills are, combined with a solid understanding of the why behind the symptoms.
Absolutely. That's exactly it. This deep dive, I hope, shows you why getting a good grasp, a swift but thorough grasp, of these conditions is so incredibly important. It really is about being equipped to recognize those subtle cues your patient is giving you, to prioritize your interventions effectively, and to provide that comprehensive care and education that makes such a difference. So what does this all boil down to for you? Here's a thought to leave you with. We've seen how many of these conditions think about NASH, alcohol-related liver disease, chronic pancreatitis, even gallstones to some extent are profoundly influenced by lifestyle, diet, alcohol use, obesity. So thinking beyond acute care, what truly innovative strategies could nurses pioneer to help shift the focus, to move beyond just treating these conditions towards preventing them on a much broader population level? What might that look like? Something to chew on. Thanks so much for joining us on Deep Dive.